We do have a society for cancer immunotherapy. Howard's actually on the board of that society as well, so we do work closely on a lot of these issues, which is always a pleasure. So I'm going to give a talk now that's sort of projecting into the future based on ongoing work, ongoing clinical trials, some drugs that are coming through the pipeline in order to put them in a framework to make it a little bit more easily digestible. I'm going to give some cartoons about how we think all of these drugs are working. Otherwise, it can swim around, sort of in a confusing way in our heads. And because of putting it in the context of these mechanisms, a few slides are going to feel a little bit science-y, right? But I hope that's okay, and I think that it helps actually to remember the drugs and their mechanism of action. And I want to raise the point here that in the past, I would say a lot of oncology drug development and development of new therapies for different cancers, not just melanoma, has really been unidirectional, starting in the laboratory, studying basic cancer biology processes, developing drugs, and then moving them into patients. And now what's happening quite a bit more, and this is in part what's accelerating the progress so rapidly, is that information is going both ways. And we're learning a lot more from the patients by analyzing their tumors and then figuring out why things are working and why they're not working. That's now fed back into the laboratory in an iterative process where we're learning more and more from each of these trials. So maybe there are some of you here who have participated in such clinical trials or have family members who have gotten biopsies on these studies, for example, or a lot of blood tests participating in these studies. And this is why. This is how the science is being catalyzed forward. I also was originally slated for about 45 minutes, I think, when this was after lunch. I'll try and trim it down a little bit so we don't delay our noon meal too much. So now let's get started. These are my disclosures, companies I interact with for participating in these clinical trials largely to help move the field forward. So for the immunotherapy of melanoma, this is what we're trying to achieve. This is actually a real microscopy picture of a T cell, a cytotoxic T cell from the body's immune system, recognizing a cancer cell and killing it. You could imagine there are these processes that are extending from that killer T cell that are embracing that tumor cell and delivering a kiss of death, right? And within minutes after this, when you study it in the laboratory, those tumor cells are destroyed. Once they're dead, they can't come back. In patients, you can pull out from the blood of melanoma patients such T cells, and you can make a tumor cell line from their cancer, grow it in the laboratory, and you can put those two together, and in essentially all patients get T cells that can kill the tumor in the laboratory, obtained from that patient. But despite that, at that moment in time in that individual, the immune system was present, and the melanoma was present. And so something must have not happened correctly for the melanoma to be allowed to arise. So the melanoma must have figured out a way to escape that immune response, and it's that understanding that is leading to some of the new immune therapies to restore that balance so that the immune system can work again to then eliminate that cancer. So this is this interaction in a little bit more detail. We know that these cytotoxic T cells are seeing specific antigens expressed by the cancer. Antigens are usually proteins that can be recognized as foreign by your body's immune system. These antigens are actually recognized as little pieces of proteins that are only 9 amino acids long, typically, so they're very small stretches. But your immune system has the capability of finding differences in those small peptides that are abnormal, surveying your body, the cells from your body, to see if there are any abnormal signatures of peptides present. These tumor antigens and the genes that encode them have been cloned. Thousands of tumor antigens have been identified now molecularly. The first one was in 1991 by an investigator in Brussels, Belgium, named Terry Boone. I had the opportunity to go to his laboratory to do some research many years ago now, and that helped to orient myself and my research group into this field. And identification of those antigens has enabled a lot of downstream work to proceed. First, it's been possible to now measure immune responses in patients. You can see, does the patient have an immune response against their melanoma or not? These assays can be very quantitative, and we have to be quantitative in these ways, just like we measure a complete blood count or a creatinine on typical blood tests. It's also been possible to develop and investigate vaccines based on those antigens. And through this iterative process that I alluded to, it's made it possible to understand the mechanisms of success versus failure, because we have stuff to measure, okay? And then a variety of vaccine approaches have been developed, but also other immunotherapies that we can give to patients, like ipilimumab. And when we do so, we can measure the effects on the immune system. We don't just have to give the drug and then see if the tumors shrink. We can understand mechanisms of success versus failure with all of these immune therapy interventions. So I sort of alluded to this already, that the paradox that if melanoma antigens are there in the tumor, and we can find T cells, cytotoxic T cells from the blood of patients, and even in the tumor in some patients, that can recognize those antigens, then why is the tumor there at all? And if we understand how the tumor has escaped this process, this is going to point us to therapies to try and restore it to normalcy and get the tumor to go away. So what I want to do now is put this in the context of how we think things work when an anti-melanoma immune response does happen successfully. And we've worked this out not just in my laboratory, but in many laboratories in our field. We meet at various conferences, including our Society for Immunotherapy of Cancer meeting, to discuss the latest data and tweak these models. But I'll sketch it out in a way I hope that is understandable here. So the way we think an anti-tumor immune response, or in particular an anti-melanoma immune response, normally is generated when things do happen successfully is like this. We think that we have to think about this as at least two compartments. There's the melanoma that's growing, and then there are the lymph nodes and spleen, the immune organs from the host. And immune responses get activated in the lymph nodes. And the tumor is usually, sometimes it can be in a lymph node, but usually it's not in a lymph node, right? So somehow there has to be communication between those two compartments for this to work. Most people have direct experience with lymph nodes being activated when there's an immune response going on. For example, if you have a sinus infection, ear infection, some kind of upper respiratory infection, you can often feel enlarged or tender lymph nodes in your neck, for example. And so that is the process of T cells getting activated in those lymph nodes. In that case, so that they can circle back to that tissue and get rid of the virus, the virally infected cells. So the same thing is what we think happens when a cancer, a melanoma, is successfully recognized by the host immune response. So this is complicated, right? You have to have somehow information that there's danger present in that cancer, and antigens from that cancer, and they have to somehow get delivered to a lymph node or the spleen or some other part of your immune system. So the way we think that happens is that there's another white blood cell called a dendritic cell. I'm going to throw a lot of terms out here. The specific terms aren't that important, but if you hang on to some of them, it'll probably be useful in discussions when you're in the clinic and you or family members or friends being considered for different clinical trials. These terms will come up in such trial discussions. So this cell type, it's a white blood cell type called dendritic cells. These cells pick up antigen and other stuff in the tumor, and they actually traffic through lymphatics into the lymph node, and then they sit in the lymph node and wait for T cells to come by that might see those antigens. When the right T cell that can recognize one of those antigens sees the antigen there, it stops and it starts to become activated. And these T cells then transform, they differentiate into the killer T cells. those killer T cells, once they're produced, you have the tender lymph node when you have a cold, for example, they leave the lymph node, and then they go back into the blood and they look for where the danger is. In the case of melanoma or other cancers, they have to home back to the tumor site. All right? And only once they home back to the tumor site do they have access to tumor cells and kill them. All right? And so when everything happens correctly, this, we think, is the cascade. But there are so many steps involved. You could imagine there are many opportunities for the tumor to screw this up or to evade. Right? And we know now from this back and forth work between the clinic and the laboratory that this can get screwed up basically at all of these levels. And knowing that then has pointed towards ways to intervene to overcome those blocks in the process. So just to go through this again, if this initial process of picking up antigens and moving to lymph nodes is defective, well, we can bypass that. We can vaccinate the patient and bypass that block. So that's the rationale for melanoma vaccines. Maybe this activation, even when we vaccinate, is partial, and the cells of the immune system are so tightly regulated that they sort of start to be activated, but they can't fully take off. And we know what a lot of those regulatory points are now that control positively and negatively sort of the accelerator and the brake of the T cells of the immune system. And now what we can do is target those with drugs. And so that's called co-stimulation as this general category. So we can now manipulate these pathways to make those T cells go better. Maybe you get a little bit of really good T cell activation, but just not enough, right? That in terms of quantity, where for some reason war and military or football metaphors really work well for the immune system fighting the cancer. So maybe you have a really skilled army, but just not enough soldiers in the army, right? So it's a quantitative defect. And so here we can try and expand those cells to larger numbers and then hopefully tip the balance in favor of the offense of this army trying to destroy the tumor. It's possible that you could have a great immune response, and we've tested this in patients. We have some patients who have not received any treatment. We get a blood sample, we measure their immune response. They've got a rip-roaring immune response in their blood that we can measure. But if those T cells don't leave the blood and go into the tumor, then they can't do anything. And we've identified a block here where trafficking of the T cells into the tumor is defective. And then we have to think of ways to make the tumor look dangerous so that the T cells know where to go. And then finally, all of this can happen correctly. And we know about 40% of melanoma patients or so actually have had all of this occur correctly. And we can find in their tumor T cells that are capable of recognizing their tumor. But it's not interacting properly. Those T cells are shut down once they get in the tumor. And so here we've, as a community, identified these negative regulatory points that turn off the T cell once it's in the tumor. And now that those are identified, we can block those and maybe restore the function of those T cells. So all of these things are potential blocks in individual patients, and all of them are being addressed now in the laboratory, but also in clinical trials that are ongoing, and some with already promising results. And so it's on this cartoon that I want to now go through some of the therapies, and hopefully you'll see where they fit into these mechanisms. So vaccines. Vaccines have had a lot of sort of fits and starts over the past, I would say, decades. Many different vaccination approaches have been pursued, both in the laboratory and the clinic. Some of these have had interesting early results. Some of them are complete failures. I think a lot of the reason that some of them have not worked as well is because of all these downstream effects that can still be preventing the success of those vaccine-induced T cells. But some of you are probably familiar with some of the vaccine platforms. We have current vaccines that are very potent, that can induce very strong immune responses against those antigens. And the best of these vaccines is already having beneficial effects in patients. I want to I'll show just 2 slides about a vaccine approach that we have explored at the University of Chicago. I don't want to go through a lot of details, but I want to tell a little bit of the story so you see how these things progress. This was a study in mice. We have animal models in a lot of our research groups, including mine, where we test some of the interventions in the laboratory before they go into the clinic and work out the details. When we did this, we found that there was this interleukin called interleukin-12 that really boosted the immune response in those mice. If we took away the IL-12, this interleukin-12, we lost that immune response. And all of these mice, when they made this immune response, could destroy their tumor. So that was an example then where IL-12 became available for clinical use. We tested this vaccine platform in patients. We had patients who had responses to that vaccine. Overall, the response rate is only 10%, with about another 20% of patients having stable disease. We had several patients with complete responses, but it's not high enough, right? It's not as high as we would want. And the question comes up, why is everybody not having that successful tumor shrinkage, right? Well, with the immune system, since we know all of these steps, we can now figure out where the defect is in those patients. The ones who had the tumor shrinkage, what happened successfully in those? The ones that failed to have tumor shrinkage, what didn't work in those patients? And that's something that I'll come back to in a few minutes. So that's an example of a vaccine where there are interesting preliminary results. And there are a few other vaccines that have moved all the way forward into more advanced clinical trial development. Some of you might be aware of the MAGE-3 protein vaccine that was developed by GSK Bio that has just now proceeded all the way through phase 3 clinical trials on an international basis, and we're awaiting the results now of those trials as I think an important lead candidate. Okay, so co-stimulation. Dr. Richards already touched on ipilimumab and CTLA-4. CTLA-4, what IPI is seeing is an inhibitory receptor on activated T cells. And when it is bound by its partner, its ligand, T cells are shut down. And the immune system is so tightly regulated, basically to prevent autoimmunity, right? I mean, you could imagine that if your immune system has these millions of lymphocytes, of T cells, that could see this universe of antigens, some of those could be expressed on normal self-tissues, right? Your lung, your heart, your liver, whatever. And so you have to guard against that autoimmunity, so these inhibitory checkpoints are in place to control your immune response. So in a way, a tumor has evolved, has developed out of a normal self-tissue and is just a little bit different from normal self. It's abnormal now, but it's just subtly different. And so these same immune regulatory pathways control the immune response against the tumor. And we know in many cases, by the time the tumor is developed, we're in a phase where these inhibitory pathways are dominant now, right? And so we'd like to block those inhibitory pathways, and that's the purpose of ipilimumab. So in animal models, again, this was done more than 10 years ago. Antibodies against CTLA-4 could augment the immune response against cancers and then cause cancer regression in mice. Finally, 2 companies then decided to move this forward into the clinic, and you know, ipilimumab was approved by the FDA earlier this year, and I think all of us participated in clinical trials with these anti-CTLA-4 antibodies in Chicago and elsewhere. So this is a picture of, just so I think it's easier to remember, if this is that T cell that's becoming activated, this receptor CTLA-4 gets upregulated and turns off that T cell, and ipilimumab is blocking that interaction. That's the cartoon. So these are the data from the randomized trial that John Richards presented a few minutes ago. This is the first, believe it or not, this is the first therapy that's ever shown improved overall survival in metastatic melanoma patients, ever, right? We've never had a drug that has been shown in a randomized clinical trial to improve overall survival. The important thing to note here is the tail on the curve, and Dr. Richards alluded to this as well, that prolonged clinical benefit is what we're seeking, right? And immune therapy has this property, right? If you can recruit your body's immune system to help destroy and control cancer, it's this process that can give durable, complete responses, right? Or durable tumor control, even if they're partial responses, not just in melanoma, but in other cancers. So what the goal of all of this research is to, here the tail on this curve is around 20%, right, at 2 years. What we want is to raise the tail of that curve, all right, and make it 20%, 40%, 60%, 80%, get as close to 100% as possible so most of our patients can have this durable clinical benefit. And I think if we figure out all of these details, which involves a patient-specific therapy approach, right? You could imagine 10 years from now, I think we're going to be getting a biopsy, maybe some blood tests on patients. We'll know exactly what the problem is in that patient. We pull the drug off the shelf, give those drugs to that patient. And for that patient, therapy A might work. For another patient, therapy Z might work. Right? Okay. Dr. Richards already showed some of the amazing clinical responses that can happen with IPI. And this is just one of the pathways that regulates the host immune response in this way, and many others are being characterized and studied in the laboratory. Multiple of these also have drugs that have been developed to target them that are also in the clinic or about to enter the clinic. Okay, so that's initial T cell activation and regulating these co-stimulatory pathways or checkpoints. How can we expand T cells further? Well, this is the drug that's been, the immunotherapy drug that's been around the longest, and that's IL-2. IL-2 in the initial studies gave about a 15% overall response rate, but about 5% of those patients had durable, complete responses, right? And again, it's the tail on the curve that made it attractive, that earned FDA approval, meaning this durability of response. The possibility then comes up of combining IL-2 with a vaccine. You could imagine now, oh, let's increase the number of tumor-reactive T cells in the patient's blood, and then let's expand the army, tenfold or whatever, by giving a growth factor that can increase the number of those cells further. And so Steve Rosenberg's group at the National Cancer Institute studied a very small series of patients where they combined an early vaccine, which is not one of these current state-of-the-art vaccines that have made it through to phase 3 trials by companies yet. But still, it was an early signal where they found they treated 19 patients with this vaccine plus IL-2, and 42% now had tumor regression. So that's higher than what had been seen with IL-2 or with these vaccines alone. And so that went to a randomized trial that was not done by the National Cancer Institute or by a company, but by a team of melanoma oncologists, right, around the country, driven by Doug Schwarzentruber. And although this is a very modest improvement, this is the fraction of patients on the tail of this curve with the combination versus IL-2 alone. There's a little bit of a statistically significant benefit here. So this is modest, but it's starting to plant the seed that when we combine some immunotherapies, we may start to see an additive benefit or a synergistic benefit. And for sure, that's where the field is moving into the future. All right, so an alternative strategy is to forget about all of this stuff. It's too complicated. Got antigens, vaccines, co-stimulatory molecules, cytokines, all these things to expand T cells. Why don't we just grow up the T cells in the laboratory and just infuse them like a blood transfusion? Right? And so this concept is called adoptive T cell therapy, and also has gone through a long history of fits and starts. And I think the most recent results are really quite encouraging. And I'll just give you a few examples. The idea here, as it's, again, been developed mostly at the National Cancer Institute, but now this strategy has been confirmed in at least 2 other centers. The more people that try something and get a positive result in patients, the more likely it is to be generally true. The main approach that's furthest along involves removing a tumor from the patient, and then surgically, and then it's taken back to the laboratory, and then the lymphocytes, the T cells that are already in that tumor, are grown out. And I mentioned to you that about 35–40% of melanoma patients have T cells in their tumor already, capable of recognizing and destroying them, but they're shut down. Turns out if you take them out of the tumor and then grow them up in the laboratory, they're functional again. Right? You took them out of that suppressive, aggressive, toxic microenvironment, and you made them work again. And so their idea was, well, now why don't we just infuse them back intravenously into the patient like a blood transfusion and have this huge army now of T cells that can go back to the other tumors and destroy them. So it turns out if you just do that, it doesn't work. And what had to be done was to give some chemotherapy to the patient, not to treat the tumor, but to get rid of the other lymphocytes that were in the patient already and sort of make space for the T cells that you were infusing. And we know a lot more about the biology of how this works, but this was the trick. And so if you combine then giving this chemotherapy that knocks down the other T cells, gets them out of the way, and now you infuse the T cells that were grown up out of the tumor, now the response rate is about 50%. And so in this first trial, they found 6 of 13 patients responded with this approach. I don't know if you can see some of these from this original paper from 2005, but some of these are very large tumors that respond, sometimes completely. And this greater than about half the patients responding is held up in subsequent studies. One thing to keep in mind as you maybe read about this on the internet or see this on foundation websites or clinical trials websites is that only a subset of patients can get this therapy. Right? If you think about it, you have to have a tumor that's resectable surgically. That tumor has to have T cells in it. So if it's not one of these tumors that already has T cells in it, you're not going to get any T cells that grow out. And so those patients are not counted in the denominator, right? And so on. And so you have to still be, have a good performance status, be in good physical shape by the time the T cells are grown up and then the therapy is infused. And so half the patients that get the therapy respond, but if you think about the patients who didn't qualify because they didn't have T cells, their tumor grew too fast, and so on, the denominator is actually a little bigger than that. But still, for the patients who do qualify, the responses can be noteworthy. Okay, so finally the tumor site. So I mentioned that, even in that case where you're growing up these T cells, you had a tumor that had T cells in it. And if you think about it for a second, it means that tumor site has supported the entry of T cells into the tumor, right? The rest of the patients, they have tumors that have excluded the T cells. And so despite that, that should be the most favorable group. Only half the patients respond. So why is that, right? So there must be other events that are happening at the level of the tumor that are either keeping the immune system out or allowing the T cells in and then blocking their function or turning them off once they enter the tumor. And so in order to get at these mechanisms, it's been necessary to biopsy those tumors. Many of these studies have been done in patients on such clinical trials, and then interrogate the tumors and figure out the mechanisms of resistance. This is sort of the last barrier that the field is having to overcome. And some of these experiments have used a technique called gene expression profiling. You may be aware that there are technologies now where you can identify the expression of all the genes from the human genome in a tissue, in a cell, in a normal tissue, in a cancerous tissue, from the cancer cells, from the other cells that are maybe in the same tumor, from the immune system, and so on. It's also possible now, you may have read, to sequence all of the genes in a cancer. And this way you can identify all the mutations in that tumor and figure out correlations with response versus lack of response. All of these kinds of things are ongoing in these translational clinical trials, going back and forth between the patient and the laboratory. And one thing that was found was that a subset of patients had, the ones who could respond to immune therapies had a certain signature. So there are certain genes that were on in the tumors from patients who benefited from cancer vaccines. It turns out a very similar set of genes is on in the tumors from patients who benefit from ipilimumab and from high-dose IL-2. And that set of genes they're not genes made by the tumor cells. They're genes that are characteristic of the immune response. And I'm not going to go through a lot of the details, but these genes are related to trafficking. They're proteins that attract the killer T cells into a tissue. If those chemo-attracting proteins, they're called chemokines, if they're there, T cells can gain entry into the tumor. It's like an address, so the T cells know where to go. If the right address is in that tumor, those are the patients who stand to benefit from immune therapies. And what it means is that we have these two categories of tumors now, of melanoma. And some melanomas are completely boring, bland. It's just melanoma cells, a few other cells, and that's all. They don't have these factors to pull T cells in. They don't have inflammation. And these non-inflamed tumors, as we call them, these patients are the ones who do not appear to be responding to our current immune therapies. On the other hand, we have these tumors that are inflamed. You can't probably see this, but all these dark dots, these are killer T cells in that tumor. Most of this tumor is killer T cells, not melanoma cells, right? These tumors can obviously let the T cells in. They have melanoma reactive T cells there. And these are the patients that seem to be responding to immune therapies. This idea that there might be a marker for patients who stand to respond to our immune therapies, this is now being tested in large prospective clinical trials, and including that GSK MAGE-3 vaccine that some of you may be familiar with already, to see if it can be tested prospectively. If it's true, then you could imagine for our current immune therapies, we would, just like we do a biopsy and check for BRAF mutation status, we check for c-KIT mutation status, we'll be doing some kind of gene signature to see if that is a good patient to assign to an immune therapy trial. And I think this is going to come within the next several years if this is confirmed. All right, so is there anything we can do then to make this tumor attract T cells? So here there isn't a strategy in the clinic yet, but in the laboratory we have strategies where we have molecules that can attract T cells. We put them in the tumor, we can get complete control of the tumor associated with the ability to attract those T cells in. And there are companies considering this technology now to see if we can take it into patients. So this is ending up being a major question. How can we make the boring, non-inflamed tumors inflamed enough so they open the doors and allow the immune cells in so that they stand a chance to destroy the cancer cells? It's a big barrier, is that opening that final door. The final category then, and then we can go to our discussion in lunch, is the inhibitory factors that shut off the immune system once the cells are in the tumor. And again, the identification of these mechanisms has been made possible by having our surgical colleagues biopsy patients. We send them to our labs, we interrogate them with the help of pathology, with these technologies, all in this team-oriented science that happens in academic medical centers. And what we found out was these tumors that are inflamed, full of the activated CD8 T cells, the killer T cells, they're the ones that have defined inhibitory pathways that turn them off. And I'm going to tell you some of the names only because a lot of the clinical trials ongoing now in the US are with drugs targeting these now. And one of them is called IDO, and I'm not going to go through the details to explain them, but just to give you their names. One of them is a molecule called PD-ligand-1 that engages a receptor called PD-1. I will say that this is a cousin of CTLA-4. It's an inhibitory receptor that's on activated killer T cells and other cells, and that turns those T cells off. In this case, the T cells that are activated, the killer T cells that get into the tumor, they have this receptor on their surface. The tumor cells express this molecule that engages that receptor. So the T cells come in, boom, they're immediately turned off when they engage the tumor cell, and then that's it, right? So the tumor's figured out a way to turn those T cells back off, and that's true for these other mechanisms too. A third one is a type of cell that's called a suppressor cell or a regulatory T cell. These guys extrinsically turn off the killer T cells. And a fourth mechanism is called T-cell anergy. It's a way that the T cells get turned off internally within the T cell. And I only put it up here to mention these names because there are clinical trials ongoing to reverse this process and get those activated T cells to work again. I did want to make an analogy that the tumor didn't invent this on its own, right? These ways to counter the immune system. These are normal regulatory mechanisms that control immune responses. And it's really interesting to note that this whole process is very similar to what happens in the placenta. That if you think about it a little bit, there's one time point in normal biology where it's absolutely critical for your immune system not to reject something that's foreign, right? And that's during pregnancy. The fetus is half foreign to the pregnant mom, right? And normally your immune system should eliminate things that are foreign, but it doesn't. And the reason it doesn't is because all these mechanisms are on in the placenta to prevent rejection of the fetus. That's called maternal fetal tolerance, and the tumor has basically reestablished a microenvironment that's very similar to that. So we have blocked all of these in the laboratory. They all can have effects in animal models. And this is an example where we can manipulate just that PD-1 molecule and have complete elimination of a tumor. And so in the clinic, an antibody was developed, just like IPI, right, to block PD-1. And this has now gone through phase 1 clinical trials. And this is a kind of waterfall plot like Dr. Richards showed for vemurafenib with patients having tumor shrinkage. These are advanced patients of various cancer types, and we've just pulled out the melanoma patients who were on this early phase clinical trial. And you can see that more than half the patients already, just with a couple of doses of this antibody, despite all their prior therapies that have failed, now have tumor shrinkage with this antibody. There is an antibody also against the ligand called PD-ligand-1. Both of these are in clinical trials at our site, and I'm sure at some of the other sites in Chicago and in the Midwest, to carry this forward now in phase 2 trials, specifically in melanoma patients. Not to go through all of these, but at our place we have, at the University of Chicago, clinical trials to target all of these pathways, either ongoing or in the pipeline, waiting in line, ready to ratchet forward as each trial closes. Strategies to get rid of those suppressor cells, the regulatory T cells, to block PD-1 or PD-ligand-1, the example I just showed, to inhibit this enzyme IDO, or to reverse this process of T-cell anergy. And very soon, as I mentioned already, we'll be moving to blocking 2 or more of these things together because it's complicated. And it's likely that if you block one, the other ones can step up and their defense, and you might have to block several of these pathways together to have maximal benefit. So I hope it wasn't too sciencey. What I tried to explain was that I think these new therapies for melanoma have emerged because of this careful analysis of the tumor in patients, and then bringing that back to the lab to figure things out. Some of the new therapies that are promising include these more potent vaccines, the strategies to block all these inhibitory checkpoints, like IPI and the cousins of IPI, and then adoptive T-cell therapy. The next wave of these agents is really focused on reversing this suppression in the tumor microenvironment to enable the immune cells to work again. And we're also trying to figure out ways to predict which patients to assign to which therapy. Preliminary results with the PD-1 antibody says that patients who have tumors with the ligand in their tumor, those are the ones who are benefiting. And again, maybe we'll be better at assigning the right therapy to the right patient in the future. And all of these kind of scientific questions are being interrogated in these clinical trials, so we'll have a better handle on that in the future. And it's probably also worth noting that some of these strategies are also being applied to other therapies beyond melanoma. This is not a melanoma specific approach necessarily. The principles are very similar in other cancer types, and many of these approaches already have activity in lung cancer, kidney cancer, et cetera. So I wanted to shamelessly plug then our society and the meeting that we have. Some of you may be interested in this, and the Melanoma Research Foundation may be interested in this. We have a meeting every fall for the Society of Immunotherapy of Cancer with a lot of melanoma discussions. That's this November. Also, Howard and I were involved in putting together a book on targeted therapeutics in melanoma that's in press right now. And this summarizes all of the data. I only talked about immunotherapies today, but for targeted inhibitors of BRAF, c-KIT, et cetera. And then finally, I just wanted to make a metaphor that we do some diving in our family, scuba diving, and this idea of translational research reminds me a lot of scuba diving, where you start at the surface in the clinic, you dive deep down in the laboratory, you figure out, make new discoveries, right, and then you resume to the surface of the clinic and apply those back in real life. And these were taken on vacation this summer, including I don't know if you know some Hawaiian fish names, but the humu humu nuku nuku apua'a, which we took underwater, and my son put the name on here on the image so that in case I forget it, right? And so that's a great name. I think it's the longest word in the Hawaiian language or something like that. Anyhow, thanks for your attention.